glad to have everybody. I hope you like this location. I hope the empty seats don't reflect people that are standing at the Caraway Baby House. I'm a little bit worried about that, but let me tell you, we had a great, it's been a couple months since we've been here. We had a great summer meeting at the beach, and then for those of you who didn't make it to our Barron's Baseball Fall Family Night, we had a great time. If some of you were sitting at home in the air conditioner, we hate your guts because it was probably the hottest day of the year, but we had a great time anyway. So if we look at doing that again next year, it'll probably be in June. I'd like to thank everybody for coming out to our new location. You know, we had some confusion about the quarantine not being ready, but this looks like they've done a great job. We've still got the great food from Coretti, and I want to thank you very much. Let's see. Our membership continues to grow. We've got about 10 members that we've added in the last month, and I would like to recognize them. If you're here, if you don't mind standing when I call your name. Stan Miner with Momentum Telecom, Lindsay Tesson with Lambert Record Center, Sean Hood with Alabama Pain Physicians, Adam Huxhold with Focus 4 Media, Stacy Acker with Sunrise Technology, Jennifer Neal with Pulmonary Sleep Associates of Alabama, Nicole Barticky with Mad Mutual, Janara Gentry with UAHSF, and Billy Bates with Starnes Law. Thank you all very much. We hope you enjoy our little tight-knit group. Today, I would like to announce that West Med Disposal is our meeting partner. If George would come up and tell everybody a little bit about West Med. This is so weird. And then we're going to have a drawing for our gift cards.
She could have done a better job probably of telling than I ever could. And y'all much rather listen to her, I'm sure. But we're a medical waste company, and we also provide training for your OSHA and your HIPAA training requirements. We service all the state of Alabama. Starting next month, we're going into the state of Mississippi, so it's a growing venture. We're excited to be here. We very much appreciate MGMA, because I've got a room full of customers here, and I love all of you, and I appreciate the business very, very much. And it's just been a great group to be a part of from a vendor standpoint, so we appreciate it. And that's what we do. And for those of y'all that are not customers, we'd love to have you.
All right. Now for the fun part. We will draw for a gift card.
$50 Visa gift card. $461-642. 642. One of the folks at the other place.
Yeah. They not only lost out on the money.
Right. Speak up. You can play.
Yeah.
Thank you.
He was wanting to take it home with him. All right, now I'd like to ask Lenore Jones to come up and introduce our panel. They're finishing eating, but we have got a great show lined up for you today. So, Lenore.
Welcome, and we are delighted and honored to have such a great group of very distinguished medical executives with us today. Birmingham MGMA, just so you'll know, we invited all area hospital systems to be represented and participate, and the men that are representing their systems here today were gracious enough to accept our invitation. It would take the entire meeting time for me to properly introduce and list all their many accomplishments, so I'm just going to give a very brief introduction for each of them and ask that if we're ready to play up. Y'all want to come on up. All right, what I'll do is I'll introduce them and then they can come up when Jerry comes up with the question. I'm not sure if Garry has made it. Garry Gause, is he here yet? Hopefully on his way and not at another location. But with us today is Keith Granger, who is currently the President and Chief Executive Officer of Trinity Medical Center in Birmingham and has been with Trinity since 2009. He is responsible for the hospital's strategic direction, its focus on clinical excellence, as well as daily operations. He will also oversee the move to the new state-of-the-art facility on Highway 280. John O'Neill is with us today. He is currently the President and Chief Executive Officer of St. Vincent's Health System, which is a 5-facility hospital and wellness center in Birmingham. St. Vincent's Health System is part of Ascension Health, which is the largest non-profit Catholic system in the United States. He has been affiliated with Ascension Health and Daughters of Charity Hospital since 1993. He is also responsible for the system's strategic direction and operational leadership. Anthony Patterson is with us today. He is currently the Senior Vice President of Inpatient Services at UAB Hospital. He has been with UAB since 2006, when he successfully led the integration of the Highlands Hospital with UAB Hospital. He is responsible for planning, directing, and managing the current operation of the UAB Hospital. His responsibilities also include patient care, professional services, support services, and construction. Thomas Shufflebarger is currently, he is with us today, and he is currently the Executive Vice President and Chief Operating Officer of Children's of Alabama and has been with children since 1992. He is responsible for overseeing the hospital's daily operations and policy decisions. He also directs the operations and development of children's physician services, including pediatric practice solutions, hospital ambulatory care services, and business relationships with health services, foundation, and hospital-based physicians. Our modest moderator today is Jerry Callahan. He is the Director of Healthcare Services Group of Caseth & Company here in Birmingham, and we are delighted to have Jerry with us again to moderate. And at this time, I'll ask that our panelists and Jerry come, and I'll turn it over to Jerry.
He must make a grand appearance, so he'll be in just a few minutes. So we'll get going without him and catch him up when we get here. You'll also see me squinting a little bit as I forgot my glasses. I forgot I was 50 and I needed those. So, I mean, as y'all look around this room, do you just realize the talent that we've got in Birmingham as it relates to healthcare executives? It's just amazing. The quality of the folks that we have in our city, and the quality of the hospitals, and most importantly, the quality of the health care that we have available. So, you know, Birmingham is just incredibly fortunate to have these systems represented in these hospitals, and through these gentlemen that have donated their time and are willing to share with us. So, I just want us to all be thankful for really what we do have in Birmingham. It's just absolutely incredible. As we get going today, some of these questions we've had before, but as with healthcare, the same things tend to just keep cycling around, and it's just that the landscape keeps changing. So you'll hear some of these questions from last year. I think you'll hear a little bit different answers from last year related to some of them as well. I guess a good place to start is we last year talked a little bit about the Medicaid program and the RSAs that are coming around, and I guess I'm going to get each of you's perspective as to kind of where those things are at this point. So, let's see. Did we draw beforehand and say who to start? Keith, you look like you're ready. Why don't you start for us?
All right. Well, I'll a couple of thoughts about the RCO, and then invite and let everyone else kind of layer in on that. If you are aware, in our state there are 5 RCO districts established by the state plan. each of the individual geographical areas that are designated for such development do in fact have work underway in those areas. There are different groups in each of those 5 regions kind of taking the lead. Obviously, the area you're probably most interested in is in our Birmingham region. Region B, as it's referred to on the plan. And Viva, UAB, and St. Vincent's are kind of taking the lead in the development of our region, and certainly would invite additional comments that may be there. As a provider facility, in this case a healthcare institution, hospital, we have the opportunity, or had the opportunity, to either make some decisions about risk bearing, about investment, or simply being a provider. I would say that the vast majority of hospitals in our region will be providers only. They will not necessarily take on investment risk, but they might enter into a risk-based contract depending on the final evolution of that region's plan. So again, we're still in the stage of trying to figure it out ourselves as it relates to our individual institution. I commend those who have been trying to work on that in our region and around the state to develop it. I would tell you that there's probably still some question marks in many areas of the state on whether this plan will in fact come together and will in fact the risk that's required to be taken by each of these areas. Is that risk sustainable once the payment levels and the available funds from CMS are determined? There's a lot of uncertainty, but you can't wait till you get all the answers before the preparation has to occur, and you need folks that are working really hard. Again, my hat's off to those who have attempted to do so in our region, and certainly thank them for that.
John, you want to go next?
Sure.
I certainly agree with everything that Keith had to say. As I may have mentioned last year, the nickname of this Medicaid plan is the Nancy Pelosi Health Plan for Alabama, because we passed it and then we'll figure out what's in it. And that's pretty much what we did. And we did that because it was that or allow someone else to come in and run Medicaid for the entire state. And that really was the alternatives that we had. We worked with the legislature to develop an RCO type structure, and we're moving forward with that. It is extremely complicated, but what we need to know is essentially that we are going to take full risk for the care of our Medicaid patients. And that's going to be very difficult. It's going to be a new way of providing care. It's going to entail many different types of providers. It's not just going to be a typical fee-for-service, go to the emergency room and see how we take care of these patients. It's going to involve a full continuum of care. This continuum of care may have everything from a neurosurgeon to an HVAC technician involved, because if we see a pocket of Medicaid patients who are admitted for pneumonia but they don't have air conditioning, it may be up to us to provide air conditioning for that patient and their family so that they don't go to the emergency room anymore. So it's a whole different type of delivery system that's going to entail a tremendous amount of information technology that needs to be available, but it is going to be an opportunity for us to see how we truly take care of a population in a different way. And so I think that behooves us, and I don't know, are you going to ask us a question about Medicaid expansion?
Absolutely.
Okay, and I won't touch on Medicaid expansion because it certainly plays into this, but I think the RCOs are still very much under construction. We're working hard to figure out how it's going to work, and so is the state. And at this point, there's no guarantee that this is going to make it. We're going to do everything we can to play our part. The state has a very large role in figuring out how this is going to work, and they're not even sure yet how they're going to be able to manage all this as well.
Gary, I'll let you get one done now. What are your thoughts about it?
Well, I apologize for walking in a couple of minutes late. I'm sure this has already been covered, but two points that I would make. One is both of them are actually political. The state needs a predictable number they can put in the budget every year for what Medicaid is going to cost. And that's a political reality. Up to now, it's been based purely on what's been consumed and with a few limits put on it. So the number can get bigger, bigger, bigger all the time. So the political reality is the state needed something that would give them a predictable line item every year that they could put in the budget that they knew would be controlled. So that's one thing that was achieved by doing this the way they've done it. The second thing that the state wanted to do was to remove the risk. They've now been able to, through this legislation, and it's probably a natural evolution of things, they've been able to transfer the risk from the state to the providers. So now, as John pointed out, it's up to us to make sure that the population health management occurs and that we can maintain low risk and we can have some margin to be able to reinvest in our facilities and in these programs. But those two things have been accomplished by doing it the way it's been done. And I think you'll see those things continue whenever we can have a flat line item or a predictable amount of expense. That's going to be what's pursued. And anytime the risk can be transferred away from the state and to the providers, that's going to continue, both physicians and hospitals and others.
Hey Tom, how does this impact you guys at Children's?
It's something we pay a lot of attention to. We about 60% of our activity at Children's is Medicaid. The majority of the Medicaid enrollees are children right now. And you know, we are the largest hospital provider in the Medicaid program, dollar-wise. So it's not just interesting for us, it's our reality for the future. I mean, I sort of echo what Garry said. The themes and the goals are undeniable, and they're the things all of healthcare is trying to do. The mechanics of this in the short run are where it's sort of dramatic and chaotic and a bit of a game of chicken. But I think the right people are working in ways to solve this. We want to solve it. I think we have a common goal that's a good one, but there's a lot to do there. It puts a burden on us to really review how we interact with our medical staffs, primary care doctors around the state for a lot of our patients. To be able to accomplish that, hospital is just one node in the spectrum of care. And making sure we've got communication, relationships with the front lines and specialty doctors are a very important part of it for us.
Doctor, I know you're on the front lines of that, so I'm going to let you kind of pull it all together for us. Talk a little about some of the, not only the operational things you're kind of going through, but kind of what you see as some of the big challenges to really rolling it out.
So, one, I'm not a physician.
You're a Ph.D.
No, that's Will Ferniany, he is. One of the things I was thinking about is I was listening to the other gentleman comment on this, is we are fortunate that UAB has a managed care company, somebody that can actually participate with providers in the state, and we will be interacting with providers in multiple of the regions throughout the state. And I think that ultimately ends up becoming a benefit for everyone. Now, healthcare in Birmingham, as you all know, we are a very competitive market. And so it's interesting to sit at the table and try to work through some of the details related to how you do this and how you do it equitably and fairly with people that yesterday you were fiercely competitive with. And to the credit of the gentleman on this panel, Mike Warren from Children's, my role is primarily internal operations, although I am generally aware of everything that's going on with the Medicaid program. And I think to their credit, coming to the table with the interests of the state, citizens of the state in mind, and pulling together a reasonable approach that will allow us to sustain delivery of care is noteworthy, and we're fortunate that that's happening. For the providers that you all represent that work within all of our hospitals, I think it is a challenge for us to consider how we work differently with them, because physicians don't look at payer class and say, well, I need to keep you out of the hospital because you're Medicaid, or I need to put you in the hospital because you're Medicare or Blue Cross or whatever the case might be. And so I think this transition from a typical volume-driven healthcare enterprise to something that looks like the RCO model does is going to be a challenge for a lot of the physicians that we will work with, and a challenge for us on how we communicate this and how we structure healthcare moving forward.
How many of you, as providers have expanded your Medicare roles over the last year? How many are evaluating whether you should? That's very surprising. Quick poll of the panel, how many of you think they should be considering how they should evaluate their Medicaid population? Anybody think they should be looking at Medicaid?
I mean, honestly, I think if they're not looking at how they can expand access, they probably should be looking at how they can provide care more efficiently to that population. Because if things continue the way they are, all the payers are going to look much more like the government payers before this is all over.
But as you looked at the Affordable Care Act and as you had the enrollment in January, the largest amount of new enrollees was into the Medicaid programs out of all. So providers are looking, I think, or should be looking at how they're going to provide that care, as Gary's talking about. John, you kind of hit on that question a moment ago. Talk to me about your system and how it views Medicaid expansion.
Well, we are a firm supporter of Medicaid expansion for a couple of reasons. One is we are strong supporters, and we believe that everyone in this country should have some sort of coverage and should have access to health care. And so our system is very supportive of Medicaid expansion for a couple of reasons. Now, you've heard all the study. UAB did a study. Most of the discussion has been around the economics of Medicaid expansion. And so, just so you know, if you don't know, that every day that we do not expand Medicaid, $3,924,000 goes to California and New York. That's not my comment. That is directly from the White House. That is the money we leave on the table every day that we do not have expanded Medicaid. And every state that has expanded Medicaid, you have seen charity care go down, you've seen access go up, and you've seen care get better. So I believe that it is very important, and we are making a huge economic mistake by not expanding Medicaid. And I think that can be proven by the numbers. And UAB certainly did the study that said that even when it gets down to us coming up with the 10%, there would be more than enough incremental tax revenue from expansion to cover that cost. So that's the economic side. But that's not what we're all in this room for. There's 300,000 people that would be eligible for Medicaid expansion that are the working poor. They can't afford to go out and get health insurance. They can't afford to pay for a policy, and they're not lazy, they're working. They deserve coverage, and we're not giving them coverage. So I think that's a real issue that the state's going to have to grapple with. And I did meet a couple of weeks ago with the Chief of Staff of the Governor, who is very supportive. I think you will see some Medicaid expansion once the election is over, gets into the politics of it. We can speak all day on that. But I do think that it is a care issue, and also it's having a significant economic issue, not only on hospitals and providers, but when you get into the discussion about should you be looking at your panels, what it's going to cause us to do more than anything else is we should be having the discussion of how are we going to care for patients and what's that delivery model going to look like, because it's not just Medicaid. We're going to do the same thing with Medicare, Medicaid, and the commercial payers also are going to be looking at how do we provide the right care at the right time in the right place. And that is a significant discussion because in Alabama, we have the most efficient hospitals anywhere in the country. These guys have heard me say it to the point where they just want to slap me. But it's true. You can compare us against anybody in the country. We have the most efficient hospitals. The only way we reduce the cost of health care in Alabama and essentially across this country are the four most expensive words in health care: massive, unexplained clinical variation. Our physicians and our hospitals have to come together and decide how we're going to provide care, and we've got to do it the same way. You can't set it up 14 different ways because I have 14 different doctors that all want to do it their way. You can't do that anymore, and if we can figure that out, then we'll be able to provide the economics and provide that care for all the people that live in the state.
Keith, on the for-profit side, how do you guys view Medicaid expansion?
We certainly agree with many of the points that John's made about having everyone in this country having some type of coverage. Certainly makes sense, and the reason for that is pretty simple. Those of us as taxpayers who are currently paying our way, we are in fact being asked as a part of these various programs to provide coverage for other groups. The reality is, in the absence of providing that coverage, we're essentially providing the care and it's coming at a cost to the other consumers that we pass that on to. I think built into all of this, there are still some fundamental social issues that we've got to ultimately deal with if we're going to attack it from an insurance standpoint. And that is that if we look at where the cost of our healthcare dollar is going, it's clearly in the aged, it's clearly in the last year of life, it's clearly in those who have chronic disease, and it's in those who have many social issues, including psychiatric. If we look at the issues that we deal with in terms of our uninsured or our uncompensated care, it's almost always driven around the areas of psychiatric or social issues, with the exception perhaps of mothers and babies as it relates to Medicaid. So I think we really got to still deal with that end-of-life issue. How much money are we going to spend on the last year of life, and when do we get families to where they sit down and deal with issues such as DNR? What do I do about mama? What do I do about daddy? The fact that many families have never had that discussion. And if you're in a hospital on a ventilator, and we have 2 children in a family, one saying take them off the ventilator, another saying not, what are we supposed to do? We have no choice but to continue care in those circumstances, so we continue to create constant care. But back to the fundamental question, we believe in coverage for all of us in this country would be a great thing. It's what's fair, it's what's right, but we've got a lot of other social issues that need to be dealt with if we're going to really solve the problem.
You know, I want to comment on this concept of variation in care. I think many people, and I'm not sure what most of you think, but I think a lot of times people consider that at UAB it's so much easier to get all the physicians to do the same thing the same way. And it's just absolutely not true.
They're not right.
Well, and we're fortunate that we have physicians that are creative and want to sort of look at individualized care for our patients. So, for example, we have an initiative at UAB Hospital called UAB Care, and what we're trying to do is to get all of the faculty to agree, my words, not theirs, on a recipe for how we do X, whatever that is. And we're doing it by DRG, probably a better way to do it. That's the method we chose. Congestive heart failure, as an example. You would think at UAB, who takes care of the largest number of congestive heart failure patients? Anyone want to guess? You would think cardiologists, right? Reality is it's hospitalists. Patients that come in, they're unattached, they float to the ED, and then they need to be admitted and taken care of. And it turns out that for us, our hospitalist group, which is the single largest adult service at UAB Hospital, that is the service that's taking care of the largest percentage of CHS patients. Then you start looking at the cost of how a hospitalist generates cost to take care of that patient, CMI adjusted, all of these kinds of factors. And you have 10 providers, every single one of them are treating a patient that largely has the same amount of comorbid conditions, but with CHF, and the cost structure is completely different for every one of them. Then you start teasing apart what it is that individual providers are prescribing to the patient, completely different. Ultimately ended up with millions of dollars of costs that we consume, and there's no evidence to suggest that what we're doing is actually producing a better outcome. And so I think to John's point, if we can't get to a point where we as healthcare providers and our faculty, our physicians that work in our facilities, agree to approach care in the same way, we will not be able to afford a lot of the other issues that we're going to do. Social admissions really doesn't meet criteria for inpatient admission, but if we send this person home, they've got an abusive spouse, and we feel really bad for them. And at UAB, we have a lot of trainees that really do have a strong desire to make sure that the individual that's standing before them is taken care of, regardless of whether or not it has a real medical issue that puts them within the hospital. So we do have a lot of fundamental challenges within our healthcare system that if we can't solve them, it's going to be even more difficult to deal with the changes that continue to come at us.
Before I go any further, there are cards and I think pens or pencils on each of your tables. If you have a question that you'd like to submit, Debbie, who's going to be walking around for that?
I will.
Debbie and Connie are going to be walking around, so if you have one of those, just if you'll raise your hand with a question, that'll come up to me, and I'll figure out how to best deal with the question that you guys have got. So I do think this is a great time to ask the next question, which is, as practice managers and administrators of physician groups, how do the people in this room best work with you guys as it relates to those issues about quality of care and standardization of care? I'd be curious as to what thoughts you have about that. Garry, you want to start with that?
Sure. I think that one of the greatest transitions that has occurred and will continue to occur, the speed of which will increase in the next few years, is transparency. So if you have a physician in your practice who simply says, that's not the way I was trained, so that's not the way I'm going to do it, that might be fine, but if the common practice out there has changed or the empirical data has shown there's a better way to treat that patient, that physician has now gone from a traditional provider to an outlier. And there's not going to be a lot of exchange of data on whether or not the way that that one physician treats a patient is better than the others. It's going to be a bell-shaped curve. And the folks that are in the middle of the bell-shaped curve that are treating folks a certain way, the most common way, the most efficient way, are going to be included and are going to be rewarded. And the folks that are on either end of that bell-shaped curve, whether it be high users of resources or low outcome and quality data, will be excluded from panels. You're seeing it for the first time in Alabama. In most states, it's been going on for a long time. But United had just started dropping providers based on what they have as data on the practice of medicine within those physicians' offices. It may not be the right data, it may not be the data that they should be looking at, but it's the data they have, and that's what they're going to be using. So while the standardization of care has been in effect for the hospitals for a long time, the practices are going to have to start looking at it. If you're not, I'm sure most of you are already doing this. We're going to have to get to the elimination of clinical variation that John spoke about in the outpatient setting and the inpatient setting. Because if not, you're setting your physicians up for exclusion, reduced rates, being under focus, all kinds of different things. Now, you can argue that the data tools that are being used are not completely accurate. And trust me, I have a ton of docs that argue it all the time. My patients are sicker. Have you guys heard this before? My patients are different, my patients are sicker, my patients are older.
Less compliant.
Less compliant patients. It doesn't matter. It will not matter what they believe their patient population has, because all those factors are going to be controlled by the data.
So any ideas about how these administrators can start to get their doctors to the table to start dealing with these things in a rational manner?
I hope all of you have strong faith. Prayer is always the good first start. I think one thing that we've been able to use in hospitals, sometimes effectively, has been peer data that's unblinded. Now, we're always really shy about showing the doctors, this is where you are, this is where you're at compared to your peers. What we like to do historically is say, okay, here's everybody, and here's your number, doctor. So if you look on the graph, you're going to see where you're at. And that was great information, but what was the call to action about it? Usually not much. When you put the data up and you put everybody's name on it, and you show a C-section rate by doctor that's risk adjusted, that's age adjusted, that's adjusted for everything, then you'll have physicians that will come to you and say, I don't understand why my rate is so much higher than my peer group. And what's the impact of that? Well, the impact is that if your rate is above a certain percentage, you're going to probably be excluded from panels. So sharing the information and challenging them Amongst their peers, they're very competitive by nature, you all know that. They're not used to being at the low end of the bell-shaped curve. They're all great, very intelligent, great students, used to being first in their class, many of them. So that is usually the best first place to start for us, is to compare them with their peers, completely unblind and open conversation. After you do that, and they get comfortable with the fact that they're going to be compared to everybody else, then it usually proceeds pretty quickly after that. But you're still going to have pockets of folks that say, I would rather quit than change the way I'm practicing. And I think we're going to see a lot of folks that may end up quitting because they really don't feel comfortable changing the way they practice medicine.
Yeah, just to, how many of you received a letter from an insurance company dropping you from a panel? Anybody in this room? Okay, well, if you read, I read an article about 2 hours ago about that United has sent out information dropping you. They had an anecdote about you can always find a patient that's going to lose their doctors. Well, you know, you didn't all raise your hand. What if that? What would your doctor say if that letter comes from Blue Cross next week? You'll all have to fit. Because if you got a letter from Blue Cross, and my friends from Blue Cross are here and they're not doing it, so I'm not picking on Blue Cross, all right? Because they would work with us before they would ever do that to our physicians. But that is what is happening all over the country. So you can say that's one way we get them to the table. You can threaten them. We can sit back and react to all of this, which is what we don't want to do, or we can proactively, as practice administrators, we're constantly going to your physicians and saying, we need to get our doctors together. We need to work on how we're doing things. We need to share protocols. We need to get rid of that clinical variation. You need to push your physicians to say, how are we going to do this so that I don't ever have to react to a letter like that? If you think it won't happen, it will happen because it's happening everywhere. And when it happens, because you're either getting it from a major insurer or Medicare, because Medicare is looking at the same thing. And as we go to at-risk contracts, which we're all going to, you know about Medicare Advantage, you know what Medicaid is doing. It's only a matter of time before we're all under at-risk contracts. And so it's going to cause us all to have to do things better. I think that one of the ways that we're trying to get doctors to the table, and that is through aligned incentives, and we've been talking about this for years. If we can align our incentives and everybody is rewarded by providing the most cost-effective, efficient care, then everybody's got skin in the game. And sometimes you do that through at-risk contracts, sometimes we have co-management agreements. We're looking at different ways and even working with the federal government to say, allow us that if we can prove that we're sharing savings, if we could go to Medicare and say, for 5,000 patients, it costs you $10 million. What if we come in with those same 5,000 patients, we can do it for $8 million? Well, that's great. Everybody wins. And let us share that with all of the providers, the physicians as well as the hospitals and everybody else. When you start aligning incentives and you can really get to that type of a system, then I think you'll have an easier time getting the doctors to the table. Because as a practice administrator, if you knew that by getting your doctors to change how they practice medicine and you went to them and said, I can put $75,000 in your pocket if you will do these things, and you'll practice this way, which is good quality, and those standards are set by their peers, how many of your doctors would say, no, I don't need that $75,000? I think they'd all say, sign me up and tell me what I need to do. We need to align the incentives between all the providers, and the end result is we take better care of the patients, and everybody can win financially.
Hey Tom, how does children's go about some of these communication efforts and engaging the pediatric practices that maybe they don't already employ the physicians in the period? How do you guys address some of that?
Well, that's a great question, because the majority of our physician interaction are outside of our organization. A lot of them are faculty, we have private doctors, we have employed doctors. And, you know, I think the reality is, regardless of the structure, and they're going to keep evolving. There are a couple of things that are obvious. One, healthcare is becoming more of a team sport. So to the extent that you all, as the support for your physicians and managers of their practice activity, help, you're going to be put in dialogue and relationships with other organizations, other providers, specialists, primary care, hospitals. So you do a lot to support that. And you know, the hospital, I love it when a practice manager calls and complains about something, because that lets me know I'm not meeting somebody's expectations. There might be something we're not aware of in our little bubble sometimes in the hospital. So engage the hospital and give them feedback. I think most of us would agree that's invaluable to know when you fail or what ideas about how to do things better. I think the other part is, you know, it's obvious the business of healthcare is getting more complex. So their reliance on you all to make that business successful, to keep them happy, healthy, and they're taking care of our patients and ourselves. That role of professional practice management is more important than ever. The doctors can't do this stuff anymore. They have other things on their mind and distractions. And it's so complex that most of them just flounder a little bit when it comes to that and the whole system suffers. So
I've got a question kind of feeding back into hospitals and how they're interrelating with providers. In rural Alabama, there's a huge shortage of physicians for a variety of reasons. One of them is primary care. I guess I'm curious as to what each of you have in the way of initiatives related to kind of helping that primary care network continue to expand. But it helps everybody to get to those illnesses and those patients quicker. Anthony, have a follow on that? How you guys are approaching that?
Yeah, I help to teach a course in the School of Medicine and health systems, and we cover a variety of topics. And one of the presentations is on the topic of rural health and asking, in many cases, the medical students to enter into a dialogue with a small panel of people about what interest they might have or what would draw them to be interested in working in a rural environment. And the reality is that not only are we going to have a physician shortage in the 100 to 130,000 range by 2025, probably at least 40 to 50 to 60,000 of those will be physician shortages within rural primary care settings. Last week I asked the question of a group, and I think that this year's classes maybe there's like 35, 40 people in the room. How many are interested in primary care? Defining primary care as internal medicine, peds, general surgery, OBGYN, family medicine. I think that's it. And maybe 5. The rest of them all want to be subspecialists and have no interest in working in.
Let me guess, 80% dermatology?
They're wicked smart.
Exactly.
So I think how we approach rural communities is going to have to be different from being able to place physicians in those communities. I think, at least in the state of Alabama, nurse practitioners have some limitations of what they can do compared to other states. But I think we're going to have to look for solutions other than physicians to take care of patients in groups that are in rural communities. Telemedicine might possibly be a methodology to do that, but there's limitations on how far you can push that. Certain things you can't bill for, and so it's kind of hard to build a structure in place unless you sort of own the lives of that group, the way that the Medicaid program is implementing its strategies. But clearly there isn't growing, I do not see growing interest in primary care in rural communities.
One specialty you didn't mention as a part of that primary care that I have a question about is geriatric care. Because with Asian parents myself and a lot of my friends with Asian parents, their medical conditions begin just to build on one another. And with a lack of a single point person of care, they wind up with so many medications in their processes. Have you guys addressed geriatrics? Is that on your radar screen at all? What are thoughts about that? Anybody have a view on that?
On the inpatient, I can talk about the inpatient side. On the inpatient side, we have a geriatrics scholars program. We take anybody, it could be a nutritionist, you could be a nurse, a respiratory therapist, any care provider who has an interest, and we put them through a year-long curriculum to teach them about care of the elderly. And so lots of very simple things that you would do differently. On the Highlands campus, we went through a tremendous amount of renovations in that hospital, brought in architects to advise us and specialists on elder care to understand what colors start to fade with age. And so doing things like painting the doorways with the darker paint as compared to the wall. An older patient, if you put a nice diamond inlay on the floor in the hallway, that's a different color than the rest of the floor. Older people will see that as a hole. And how the walls are painted. So there's all these other things that I believe that we need to be paying attention to as inpatient providers, that most of us, it would be hard because it's simple little tweaks in the way that you approach it. So there's, I think, building and architectural issues, and then there's systematic education of the elderly population that we're responsible for to learn how to take care of the population of older patients.
Keith, you want to comment on that?
Sure, be happy to. And Jerry, I think you actually hit on probably what is the next big wave that, for the most part, is unrecognized yet, even though the demographics have been pointing there for many years, that the aging of America, that is the group that's going to consume the most health care. It's the group that are likely to be covered under Medicare. They're likely to be the parties that each of you, as you work each day, are perhaps worried about what happens to mom and daddy because you don't necessarily have a way to keep them at home, live independently in many cases. So the coordination between assisted living, senior care, whether it be skilled nursing, et cetera, I think is all going to have to come together. And your point about, are we producing enough professionals to take care of those needs? Those are some of the sickest people. They have the most medical complications. They have the most pharmaceuticals, as you described. And for the most part, I don't think we've ramped up the ability to do that. I think if I were a practice leader in primary care, it might be a great question to ask yourself, is this a pool of patients that I want to make as a high priority in my practice, and how easy is it for them to access my practice, both physically and electronically, et cetera. Again, I think there's a great opportunity in that area. I think you're on a topic that we've all as providers got to be addressing going forward.
Hey, John, you have some thoughts on that?
Sure. I think your original question had to do with rural health and what's going to happen. First of all, the way that currently, my prediction would be within the next 10 years that the majority of small rural hospitals in Alabama will be closed. We've already lost 8 to 10 hospitals in the last 2 years, and most of them will be closed fairly soon. And if you talk to most of those administrators, they can't make it. Now, you could make the argument and say, do you need a hospital in a small town? Maybe you do, maybe you don't. The end result is, excuse me, is we should be working with all the small communities, one, to do a needs assessment on what do you really need in your community. Do you need a hospital, or do you need a strong outpatient treatment diagnostic center? Do you need good primary care? But the end result is you need a strong private-public partnership. The communities are going to have to realize if they want health care in their community, they're going to have to help pay for it. And we're going through that process right now in Clanton. They lost their hospital. The community was going to buy it. They were going to try and reopen it. And we went to them and said, don't do it. We said, we'll work with you, but I can't pay for that. I can't take the risk to build another facility in Clanton and run it because you can't make it work. But you will go spend tens of millions of dollars to put sewers in an industrial park, but what have you put into your healthcare infrastructure in the city? And they looked at me and said, nothing. I said, if you want healthcare, which aids economic development and takes care of your population and will help deal with the elderly situation and be able to get physicians, you're going to have to be willing to pay for it. What did they do? They passed a 1-cent sales tax. It will cover the cost of a new facility. It will provide money for healthcare infrastructure, and they're going to have a state-of-the-art healthcare facility that's going to be paid for. It will be sustainable. We'll help them do it because we have that infrastructure, we have the know-how, as anybody on this panel would be able to do, but we can't take the risk for that anymore because you can't make it work in a small rural community. But through a public and private partnership, they'll get what they need. We'll be able to help recruit physicians down there. They'll be part of a bigger system, and we can make it work. But the communities have to decide they want to help pay for health care if they think health care is an important infrastructure. And in your communities, if you don't have a good tax base, good education, and good health care, you cannot attract businesses to your community. And Clanton is a good example of where they are ripe for economic development. Now this is going to really impress you. They really have good dirt in Clanton. I was told that by a structural engineer, that companies could relocate there because they have really good dirt. And it's easy to build on. But without health care, without good education, it won't happen. And so I think the communities have to come together and decide we want health care, we want to take care of our population, work with the larger providers, and we can make it work.
Hey, Garry, has some thoughts?
Yeah, let me focus in a little bit different area. We talked a lot about the inpatient care. A lot of the inpatient care could be avoided if we had more adequate outpatient care, not just physicians. You know, by any measure, by any survey you've seen, there's going to be a shortage of physicians. Right? I think we all agree that under the traditional model by which we provide care, we're not going to have enough doctors to do it the way we've always done it. So what do we need to do? We need to change the way that we're doing it. Real hot, kind of almost cliche term that we're using right now as hospital administrators is working to top of license. We've got to have physician extenders, we've got to have, and think beyond just nurse practitioners, PAs and SAs, we've got to have pharmacists. We have to train pharmacists to be able to go into these communities, whether they be with home health or independently or through a physician's practice, and do multi-pharmaceutical management. We need to get these folks off of the drugs that they're on unnecessarily, that cause them to be disoriented, that cause them to fall, that cause all kinds of complications. They don't know. They're taking what they've been told to take. So stopping, reevaluating, getting better outpatient care, better access to services like pharmacy, home health, etc., that will prevent the unnecessary admission. That helps the patient and actually will help the hospitals because we're not going to get paid for the unnecessary readmissions anyway. And the physicians are going to be at some point in the exact same boat we're in. We talked about aligning incentives. There's going to quickly come a time, and it's already happening in some parts of the country, that when they stay in the hospital denied because the patient doesn't meet criteria, the physician's not going to be paid either. So pushing the care out as far into the communities as we can. One concept that I think will work in Alabama is the freestanding emergency department. It doesn't have to be a hospital with beds and an ICU and all those sorts of things. I think you can prove that the more of that highly specialized care that's centralized into certain facilities that clearly have the ability to take care of those patients, and you're not running a 2 or 3 bed ICU, the care is going to be better for the patients as well. So having a frank conversation with where do we really need to deploy inpatient beds, what other types of outpatient emergency department structures can we put in place to complement and replace some of the unnecessary inpatient beds, and then push as many things and resources as we can to the outpatient side to prevent admissions. We'll see care improve, we'll see better utilization of resources, and we'll see patients with better outcomes.
All right, I've got 8 minutes and I've got 10 questions. So 30 seconds each. No, seriously, I've got 2 questions. I really want to get each of your input. If you will, try to keep your answer to 1 minute around that time. And I'm sorry, but there's a couple of questions, and these are from me. So the first one I have a question about is, as we talk about our practices and the shortage of physicians that we've got, what trends are you guys all doing as it relates to support agreements, physician recruiting? Are you still doing those things? So I guess I'll just start with you, Keith.
Sure, I'll try to keep it short. I think the typical employment model continues to exist as a very prevalent practice among facilities and physicians. Secondly, co-management agreements would be certainly a derivative of that, that you could not necessarily go through all the components of employment, but yet build a lot of things into a co-management agreement. Third would be professional services agreements that could define certain performance of services that link a doctor and the hospital together, and then the typical recruitment programs that are in place. So those four quickly come to mind. Then certainly you have the opportunities for joint ventures and affiliations of varying degrees depending on what you want to innovate.
So you brought your checkbook.
All you need to do is have your hand out and be reached.
I know you and Anthony probably did this situation, everything that you're doing in those reports.
Well, I would back up and say our biggest opportunity to help pediatric manpower in children's is to help train folks. So we work as a teaching facility with UAB to develop interest in pediatrics to get folks trained. About 70% of the pediatricians in Alabama trained at UAB and Children's Hospital. So that's the biggest lever we have right now. And then try to, of course, the recruitment and the mechanisms to attract them back. Keep them.
Two things at UAB Hospital. One is we've implemented something called funds flow, and this is a way where I'll say it this way, it's a form of leasing the faculty and putting them on a work review model by specialty, and then supporting the clinical departments through the clinical efforts of the faculty within that department. And that moves us away from a method of helping to fund shortfalls within our clinical departments, which we call mission support. So funds flow has been a complete transition for our clinical departments into the hospital and how we interrelate to them. And then also aligning, and we talked about this earlier, aligning incentives so that things that are good for the hospital are felt more directly by the faculty as they grow in understanding what funds flow means and how they assure the financial health of their departments. And then in integrated practice units, our first one will probably be in around our transplant services, where our faculty across multiple departments will be combined together in one unit and be managed as a unified clinical departments.
John?
We will entertain any and all arrangements that maintain honesty, integrity, and are legal.
That's the shortest answer we have.
And we're doing everything else they've already talked about.
Garry?
What he said.
All right, y'all are asking for the hard one. You really want the hard one? Question from the floor. Are ACOs coming to Alabama? Your organizations? Garry, I'll start with you.
Yeah, they're already here. There are a ton of them already in existence. Many of them are not assuming any risk yet, but there are contracts out there, and folks are experimenting with some direct contracting. I think by whatever acronym you want to name it, RCOs, ACOs, Medicaid really forced it for Alabama. In the regions, we're going to be in risk pools, and by any definition, ACOs are here to stay, and could be short-lived because they will evolve quickly into something else. But I think they're in Alabama, not as prevalent in most parts of the country.
I think the other question I've got, and this is, I continue to hear, especially the specialists that take care of a lot of unattached call in your ERs, and question about, is there any trend, both either in Alabama or nationwide, as it relates to call coverage pay or stipends along those ways? So I guess I'll start with your end first.
Certainly, it's been a bigger topic probably in other states. You typically find it in the more metropolitan areas where the pressures can be very high. I can tell you that as a facility, we try to avoid it at all costs, but we understand that it is getting to be more and more of an issue. Typically, what you find is you end up trying to fulfill some of those obligations through employment models or other coverage models, such as hospitals, etc. So it is an evolving trend. It is a trend that may break the bank before it's all over in terms of what it costs to try to put something like that in place and maintain this financial stability of your organization.
John?
Yeah, call coverage pay is not anything new. I can tell you one system within Ascension Health pays $30 million a year for call coverage, and it's not around here. Keith is absolutely right. It is a major issue here because our reimbursements are so low. that to do that would be very difficult, but it is something. Call is probably one of the most onerous issues. I'm telling you this. I mean, when you recruit physicians, almost their first question is, what's the call coverage? And if you say 1 in 3, they're not coming. And so it is a big issue, but it's like anything else. Where does that money come from? And so it is a major issue. Lifestyles are becoming more of an issue. You have to remember, 50% of the residents coming out of training are female. And that's a whole new dynamic because they get married, they have families, they don't want to work as many hours, which is a big issue. So call coverage is a huge issue because it also is a patient care issue. So it's not just the specialist. It's how do we work together as an entire system to manage those patients so we don't have to burden the physician with as much call as we do today.
Garry?
I moved my chair a little bit out because I'm looking at Cynthia down here, whose husband's an OB, and I know she's working more hours than he is. You're right. You're right. John always says what the rest of us are thinking. So. I think for us, it's particularly a challenge. If you've got more than one hospital in location, there is a way to cobble together some cross coverage. If you're a standalone facility in a market, it's really difficult, especially if you have deep subspecialty, to provide full-time coverage in every subspecialty 365 days a year. So the tough choice is to look at a specialty like ENT. Now, is there really an ENT emergency that would come into a community hospital like Brookwood? You could debate it. So what do? Do you try to go out and cobble it together? Do you try to just pay and get it covered for the once every 3-month bleed that can't be stopped that comes in the emergency room? Or you just admit to yourself that you're not going to be able to provide 365-day-a-year coverage for some specialties that are out there. It is a tough thing to do when your charge as a hospital CEO is to make sure that you're providing all the care all the time. But it's going to get worse, and there's no easy answer. Some markets have gone to a community call. Some have tried rotating the destination for ambulance service on a particular night because this certain specialty is covered at this certain hospital. There's no great way to do it. But I think the folks that spoke to it earlier are right. It is a big number that has absolutely no way to be compensated. So it is literally coming right out of the cash of the facility that could be used to buy equipment, to give raises, to do other things in the community. So it's a tough one.
Well, thank you guys. We are out of time. I do want you to just understand, these guys are excellent at what they do, and I would dare say any other profession, it would be difficult to get these guys on the stage to talk about their businesses and what they're thinking about day in and day out as they position what they do. So we really do need to be appreciative of them being willing to share their time and their efforts and their knowledge. And it was really just another extraordinary discussion. I want to thank you guys personally, and everybody will join me in thanking you.
Before you leave, again, I want to thank Jerry for moderating and for all the panelists who took time out of their very busy schedule to be here. Just to note, there's little bowls on the table that's for you to drop your name tag in, and we'll come and collect the bowls. And our next meeting will be here on October the 15th, and hope to see you here.